Welcome to AETCM. Today we're discussing about an 85-year-old female who came to ER with complaints of fever. So the 85-year-old female is brought to ER with complaints of fever since past 2 days associated with some cough and breathlessness. On my initial 10-second assessment, she was conscious oriented and she was obeying commands. Under the primary survey, her airway was patent. There was no signs of any airway obstruction. There was no stridor. There was no obvious just any airway obstruction. There was no obvious secretions or anything. Breathing part, she had a respiratory rate of about 22 per minute, and saturation she was maintaining 96% in room air. On auscultation, she had bilateral rhonchi and also some basic crepitations were also heard bilaterally. Circulatory part, she had a BP of 110 by 80 and heart rate was 89 per minute. And GCS, she had a full score of GCS by 15 by 15. But she also had some resting tremor was noted on bilateral, but she is a non-case of Parkinsonism. Exposure part, she was febrile on arrival in ER and GRBS check was 129 milligram per deciliter. So her primary survey, her ABC, everything is within normal limits only. So we went to the secondary survey. So basically, she's an 85-year-old lady. She's a non-case of previous history is non-case of atypical Parkinson's disease on medications, and also history of hypothyroidism is there. It doesn't have any previous pulmonary history as such, but since 2 days she is having some fever with dry cough with minimal expectoration and some breathlessness, which was worsening over time, which brought her to the hospital. There was no history of any vomiting, abdominal pain, loose stools, or dysuria, or any other associated symptoms. And initially, they took some conservative management at home, but symptoms were worsening, so they brought her to the hospital. There was no known drug allergies or any other history. She is taking medications mainly for Parkinsonism, that is Syndopa 125, then pramiprazole and amantadine. This she is regularly taking for a long time. She also had a history.
What are the adverse effects of Syndopa?
Syndopa, this thing.
Common adverse effects, which can come to ER. One is postural hypertension. Postural hypertension, one important adverse effect. Then altered behavior. Immediately after starting, many patients will have this agitation, altered behavior.
It takes some time to get used to the drug.
So this type of patients also can come to ER after starting Syndopa.
She also had a previous history of hiatus hernia for which she underwent a surgery about 5 years back. That's the history. So there is no any acute event that brought to the ER, but since symptoms were worsening, she came to the ER. So clinical examination, she is again conscious oriented. She had some rhonchi, so we initiated her on nebulizations in ER, and bilateral crepitations were also there, and other systems are within normal limits. We took an X-ray. X-ray was showing some haziness on the left lower zone. Haziness was there.
What was the temperature?
On arrival, febrile. But when they were at home, actually, they said actually she had high grade temperature, about 102, 103 was noted, and they gave paracetamol at home. About 2-3 spivofix per day almost every day she had. So initial counts were elevated, and also she had elevated CRP, and in view of persistent symptoms which she was admitted for further evaluation. So currently she was admitted as an LRT, lower respiratory infection, and she was started on antibiotics and other supportive medications, nebulizations and all that. She was admitted, and that day evening she actually had an acute onset of altered sensorium. But initially it was attributed to like febrile because at that time she was febrile and she was given IV paracetamol. But after that actually the symptoms persisted. And the routine evaluation, because of her bilateral crepitations and everything, we sent a cardiac enzyme also. And in that the creatine kinase came to be elevated. The first day value was 1800. And the following day the repeated, like the second set of enzymes were showing 2900 was the value, 2915 was the value. And following we mounted this value because
what of routine fevers, they can have elevated CK. Routine, what we see every day. What condition?
Maybe like
elevated CK.
Like a fever like leptospirosis.
Leptospirosis is the most important thing. And again, if you have given IM injections or any exertions before just taking blood, all these things also you can get. But leptospirosis is one important condition where CK is elevated initially itself.
Okay. So even though it was more like an incidental finding, we follow up the CK because it was elevating day by day. So by the third day, it came to 4,600. So when we went with it, we took a more detailed history, and basically she was on this Parkinsonism drugs since a very long time. But recently, about 1 week back, she had some worsening of symptoms. They went to a local nearby clinic, and there actually they started her on quetiapine along with her regular drugs. which they were not initially, they didn't initially told us because our regular drugs were only these 3 in our perspective. So this drug she was taking since past 1 week regularly, and after that she got admitted. So considering this new addition of drug along with her symptoms, we thought about attributing this to a neuroleptic malignant syndrome. Because mainly because she had elevated CK and some altered sensorium was there, and also she was showing some features of rigidity. Initially, we again attributed to Parkinsonism, but the differentiation was not very obvious. But considering the history of starting quetiapine recently, it could be related to neuroleptic malignant syndrome.
What is the type of rigidity you get in this NMS?
NMS, it'd be like more like axial rigidity.
NMS, it is lead pipe rigidity, whereas Parkinsonism, it is cogwheel rigidity. Again, a patient who is having NMS in a Parkinsonism, again it will become cogwheel. So it will be difficult to tell lead pipe alone is the feature of this one. But whatever it is, rigidity is there. Okay, both in extension and flexion, you can get increased tone.
So considering this history and looking retrospectively, basically this patient had recurrent histories of hyperpyrexia, fever was there. Then again after coming here, she developed altered sensorium, and also she had symptoms of rigidity. So again with history of starting a new drug like quetiapine, which can again induce neuroleptic malignant syndrome.
What is the sodium level in this patient?
Sodium was...
is it important?
Sodium was 139.
Sodium is very important because many Parkinson patients can have hyponatremia, altered behavior. Okay. So that is also important. You have to always look at it.
So considering her symptoms, this could be attributed to neuroleptic malignant syndrome. So our priority of treatment is mainly hydration, mainly to like prevent further...
Pupil size, that is very important. Pupil. Eye. Examination. What is the size of the pupil?
Pupils, this patient actually had 3 millimeter bilaterally reactive.
Okay, normal.
Normal.
If it is dilated, what all differential diagnosis?
One thing her
altered behavior, fever, dilated people. What are the differential diagnoses?
Serotonin syndrome should be closed.
Serotonin syndrome. One more thing.
Maladin hyper...
Atropine poisoning.
Atropine poisoning,
So you give atropine for organophosphorus poisoning. That patient you can see dilated people and hyperpyrexia. Rigidity. Some amount of rigidity
may be there. Okay. So this was actually this thing basic lab evaluation. So she had elevated inflammatory markers along with elevated CK. Electrolytes were otherwise normal.
Creatinine.
Creatinine was normal.
What is the importance of creatinine?
Creatinine was 1.4.
Okay. What is the importance of creatinine here?
Basically, as soon CK increases, it can again go secondary AKI.
Okay. So elevated CK because of rhabdomyolysis can produce renal failure. So creatinine is very important. Potassium?
Potassium is 4.6.
Okay. What happens to the potassium in this neuroleptic malignant syndrome?
Usually elevated.
It elevates because muscle injury is there. Okay. A lot of electrolyte imbalance can be there. Hypomagnesemia, hyperkalemia, hypocalcemia. A lot of electrolyte imbalance can be there. So you have to check all the electrolytes.
So as treatment part, actually we started her on IV fluid rehydration mainly to like avoid further complications of AKI. Then antibiotics we started to like control her infection and all that, because infection could again be a trigger for neuroleptic malignant syndrome. Okay. And along with that, all cultures, everything was sent. So for the initial report, cultures are negative. Blood cultures, everything is negative, and the symptoms worsened by her conservative management. But initially, we had to give midazolam also has to be given initially for her controlling her altered sensorium and some rigidity. And after that, once the febrile episode started coming down, and her symptoms also started coming down. So after the conservative management, mainly with antibiotics, rehydration, and also other supportive medications, her CK also started coming down. Now the last CK is 2,800 after the peak. So
how do you control the fever, which is not getting controlled with paracetamol in NMS?
One thing is benzodiazepine.
Benzodiazepine agitation will be controlled. Which drug?
Dantrolene.
Dantrolene and
bromocriptine can be given.
Dantrolene can be tried. That is the best drug. Okay. Then bromocriptine. What is the dose? Because the dantrolene is not available everywhere. In anesthesia setup, you have to have. But in ER, it may not be available. Bromocriptine is available everywhere. Okay. What is the dose of bromocriptine?
2.5 BD can be given.
BD or TID?
TID can be given.
4 times, ideally, it is 2.5 milligram 4 times daily. That has to be given. Okay. Then other than that, how do you control the temperature? Other than that, because it normally it will not. This is a mild case.
No.
Severe cases, it will not be controlled with paracetamol. How do you control the
Then we
temperature?
have to go about like other external means of control.
External cooling.
Like tepid sponging, then cold bladder wash, cold RT wash, and all we can be given.
Okay.
Then cold blankets.
What acid-base imbalance can occur here?
Metabolic.
Lactic acidosis, metabolic acidosis. Because severe dehydration can occur, so that can produce metabolic acidosis. Okay. What are the differential diagnoses? Suppose the patient is having, if somebody tells it can be tetanus, what is the difference between tetanus and neuroleptic malignant syndrome? Tetanus, you have rigidity, you have high fever, you have sweating, autonomic dysfunction is there. What is the main difference between tetanus and NMS? Tetanus patient is fully conscious. That is very important. Any tetanus patient you examine, patient is fully conscious. He'll have all these clinical features. Whereas NMS,
patient will be altered sensorium.
Patient will have altered sensorium. Another differential diagnosis, serotonin syndrome. How do you differentiate serotonin syndrome?
One thing is that people
is dilated in serotonin syndrome, whereas here it is normal. Third one is atropine poisoning. They also have all these conditions will have similar finding. Atropine poisoning.
Again, there could be like a background history, maybe there, like intake.
Atropine we might have given, but atropine poisoning is there. Datura poisoning.
Datura poisoning.
So they also have similar feature. They have high fever, some rigidity will be there. Bradycardia is there. There also people dilated. People dilated and bradycardia. Here, what happened to the heart rate in NMS? NMS, what is our heart rate?
Will be usually high.
It is normally autonomic dysfunction is there, so
high and low.
High and low. It will go high and low. Whereas in atropine poison, it is
usually on the
atropine poisoning. It is tachycardia. Okay. So that is a difference. One more important problem is autonomic dysfunction.
So basically, you can get fluctuating BP as well as heart rate.
How do you manage that condition? Autonomic dysfunction. How do you manage in ICU?
One thing will be frequent cardiodynamic monitoring. Then
it's alpha blockers.
Not
beta blockers. Okay. How do you what drug we have? What is the drug we have to control this alpha blocker?
Prazosin.
Either give prazosin oral or you give lebetalol. It has got both alpha and beta action. So that can be tried. Okay. Not NTG. NTG may produce sudden vascular collapse here. Okay. So patient may go to hypertension. Here you have to have a controlled system. You can give lebetalol that control the heart rate, that control the BP. It has got both alpha and beta activity. Okay, sir. What anesthesia drugs?
So there any contraindication for any of the anesthetic drugs?
One thing is suction is calling. Usually can trigger mild hyponatremia.
Otherwise, because of the age-related changes in all systems, and the demand for oxygen will be more. And one of the method of rheumatic carbon dioxide is intubation if you are already doing hyperventilation. And all electrolyte imbalances regarding potassium, calcium, all should be taken care of. Otherwise, only when we are using volatile agents, that we are not using in anesthesia setting. Avoid suctional cooling. Rocuronium
we can use.
We can use it, but some instances rarely reported. So in case if it is occurring, we have to reverse the patient with Sugamadex. Anything. Okay.
So both are totally different. Malignant
hyperthermia
and this is different. This is entirely different. Other one is Sarah's told because of the anesthesia drugs, succinylcholine. This is NMR. This is due to antipsychotic drugs. Anti-Parkinson drug withdrawal, anti-emetic drugs, okay, which is a common anti-emetic come with this problem.
Metoclopramide. Then domperidone.
Okay. Then haloperidol is one important drug we use in wards, general wards. Not only psychiatric wards, general wards to prevent agitation. Many doctors give haloperidol. That itself can produce. What other complication can metoclopramide produce other than this?
This thing.
extrapyramidal movement disorders. Okay, so that can be produced by metoclopramide. How do you treat it?
Phenergan.
Phenergan. You can give Phenergan. That can control the problem. Okay. So finally, when you are seeing NMS, what are the four important clinical features? Important clinical features.
One is hyperpyrexia, acute total sensorium. Then any recent addition of any
rhabdomyolysis and elevated CK. Dysautonomia. The most important differential diagnosis are serotonin syndrome. There, look at the pupil. Second thing is tetanus, altered behavior. Then Atrocan poisoning. History will be there. Pupil is again dilated. Okay, rigidity is less severe. Okay. What respiratory complication these patients can have? Like tetanus or your NMS or serotonin syndrome.
Mainly because of this rigidity, patient will be having difficulty to breathe, which can progressively worsen respiratory failure. And
looks like a restrictive type of lung disease. Okay. They can have hypoxemia. These are the common problems, but this patient had only mild problem. Can we restart the drug now?
No.
It is not to restart immediately. If you want to try in a controlled environment, only after 2 weeks of the initial event. Okay. So we have to wait for some time and try to avoid the drugs which are more prone to develop this problem. Okay. Anything else, sir? Okay.
So,
thank you. Anything else?
Basically, we have a diagnostic criteria which can be used for this one. So in that we have a 100-point scoring system in which the highest priority is for exposure to dopamine antagonist, which has recently started or maybe recently stopped a dopamine agonist within past 72 hours. We give a priority score of 20. And next, the history is patient having hyperthermia about more than 100.4 Fahrenheit. We give a score of 18. Then rigidity, then outer mental status, and also CK elevation. This all we be having 17, 13, and 10 score. Then sympathetic nervous system lability, like sudden varying of blood pressures and also diaphoresis and urinary incontinence. They all will have a point of 10. Then also any features of hypermetabolism, like patient is having highly varying heart rate and respiratory rate, that gives a score of 5. So basically there's no cutoff as such for this scoring system, but actually as the score goes higher, we can give it a high clinical suspicion of neurologic malady syndrome. So basically patient coming with whatever be the symptoms, anything coming under this category, we have to think about neurologic malady syndrome if the patient has recently started on a newer drug which is an antipsychotic which can come under this category. So the common drugs are like aripiprazole, clozapine, then haloperidol, olanzapine, quetiapine, and risperidone. Then in antiemetic drugs like domperidone, metoclopramide, and promethazine, they all can actually trigger neurologic malady syndrome. And the clinical features, as we said, it will be like an acute altered mental status with hyperpyrexia and maybe autonomic dysfunction. And evaluation we send for all routines, also to evaluate for other inflammatory parameters and also cultures and everything. And also by hand we also do CT brain and also rule out other causes of altered sensoria. Then differentials, as we said, it could be serotonin syndrome, then malign hypothermia, and also any anticholinergic overdose or poisoning, and also any acute intoxication with any cocaine, ecstasy.
Is the next one,
Ritura. Then any intoxication with cocaine, ecstasy, or any methamphetamine can also be having similar symptoms. And finally, meningitis or encephalitis, the patient may have similar history.
Which type of stroke will have same problems?
Brainstem stroke.
Pontine infarct. They have almost similar feature.
So the treatment part, the first one will be to stop the drug, offensive drug, whichever it is, or to restart the drug if it is a drug withdrawal case. So either starting drug and stopping drug can cause neurologic malady syndrome. And again, basic idea is to maintain the cardiorespiratory stability of the patient. Like starting from ABC, we have to continuously monitor the patient, and if required, put her on mechanical ventilation and antiarrhythmic agents, whichever is required as per the patient clinical status. Then maintain euvolemia, and also to treat hypothermia with either with antipyretics or other agents like blankets and other, as we already discussed. And to control agitation, we can use benzodiazepine, like midazolam can be used. And also the androline can be added in case of moderate to severe muscle rigidity. The drug dose will be 1 to 2.5 milligram per kilogram. IV can be started. Along with that, bromocriptine can be started like 2.5 milligram. TID can be started. This will be the basic management coming. So our patient clinically improved by about the 7th day. She improved. Now sensorium has improved. CK is coming down. Hemodynamically stable, and also her febrile spikes also have coming down. She's clinically improving.
Okay. Anything else? Thank you.